Hello everyone, welcome to part 1 of our lecture on the biomechanics of the knee complex. In this video, we will begin by understanding the anatomy and biomechanics of the knee joint. We will discuss the bones that form the knee complex, the tibiofemoral and patellofemoral joints, the movements of the knee, the important ligaments, menisci, and the factors that contribute to knee stability. A clear understanding of these basic concepts is essential before learning about knee injuries, clinical conditions, and rehabilitation. In part 2, we will explore the function of knee joint, screw home mechanism, arthrokinematics, muscle function, biomechanics during gait and functional activities, and their clinical significance. Let's get started. First, the introduction. The knee complex is one of the most often injured joints in the human body. The knee complex is responsible for moving and supporting the body during a variety of both routine and difficult activities. The knee complex is composed of two distinct articulations located within a single joint. Capsule, the tibiofemoral joint, the patellofemoral joint. The tibiofemoral joint is the articulation between the distal femur and the proximal tibia. The patellofemoral joint is the articulation between the posterior patella and the femur. First, about the tibiofemoral joint structure. The tibiofemoral or knee joint is a double condylar joint with 3 degrees of freedom of angular, that is the rotary motion, flexion and extension, medial or lateral rotation, that is the internal or external rotation, abduction and adduction. The flexion and extension occur in the sagittal plane around a coronal axis through the epicondyles of distal femur. Medial or lateral, that is the internal or external rotation, occur in the transverse plane about the longitudinal axis through the lateral side of the medial tibial condyle. And abduction and adduction occur in the frontal plane around an anteroposterior axis. The double condyloid knee joint is defined its medial and lateral articular surfaces, also referred to as the medial and lateral compartments of the knee. Next, about the femur. The proximal articular surface of the knee joint is composed of the large medial and lateral condyles of the distal femur. The medial condyle is larger with a greater radius of curvature and projects further than does the lateral condyle. Because of the medial obliquity of the shaft of the femur, the femoral condyles do not lie immediately below the femoral head but are slightly medial to it. As a result, the lateral condyle lies more directly in line with the shaft than does the medial condyle. Since the medial condyle extends further distally, the distal end of the femur remains essentially horizontal despite the angulation of the femur's shaft. The two condyles are separated inferiorly by the intercondylar notch through most of their length, but are joined anteriorly by an asymmetrical shallow groove called the femoral sulcus, patellar groove or patellar surface that engages the patella during early flexion. Next, about tibia. The large convex femoral condyles sit on the relatively flat tibial condyles. The asymmetrical medial and lateral tibial condyles or plateaus constitute the distal articular surface of the knee joint. The medial tibial plateau is longer in the anteroposterior direction than the lateral tibial plateau. However, the lateral tibial articular cartilage is thicker than the articular cartilage on the medial side. The proximal tibia is larger than the tibial shaft and consequently overhangs the tibial shaft posteriorly. The medial and lateral tibial condyles are separated by a roughened area and two bony spines called the intercondylar tubercles. These tubercles become lodged in the intercondylar notch of the femur during knee extension. This image is a superior view of the articulating surfaces on the tibia, illustrate differences in size and configuration between the medial and lateral tibial plateaus. The combined bony architecture of the somewhat convex tibial plateaus and convex femoral condyles does not bind well for joint stability. Because of this lack of bone stability, accessory joint structures, that is the menisci, are necessary to improve joint congruency. Next about the tibiofemoral alignment and weight bearing forces. The anatomical or longitudinal axis of the femur is oblique, directed inferiorly and medially from its proximal to distal end. The anatomical axis of the tibia is directed almost vertically. Consequently, the femoral and tibial longitudinal axes normally form an angle medially at the knee joint of 180 degree to 185 degree. That is, the femur is angled up to 5 degree of vertical, creating a slight physiological valgus angle at the knee. If the medial femur medial if the this image shows the anatomical axis of the femur and tibia results in a normal physiological valgus angulation of approximately 185 degree. The mechanical axis, that is the weight bearing line of the lower extremity, passes from the center of the hip to the center of ankle joint, and in a neutrally aligned limb results in weight bearing forces that are distributed about equally between the medial and lateral condyles of the knee joint. If the medial tibiofemoral angle is greater than 185 degree, an abnormal condition called genu valgum exists. If the medial tibiofemoral angle is 175 degree or less, the resulting abnormality is called genu varum. Genu varum is otherwise called bowlegs. Genu valgum is otherwise known as knock knees. In bilateral stance, the weight-bearing stresses on the knee joint are therefore equally distributed between the medial and lateral condyles, that are medial and lateral compartments. In the case of unilateral stance, the weight-bearing lines shift towards the medial compartment. This shift increases the compressive force on the medial compartment. Genu valgum, for instance, shifts the weight-bearing line onto lateral compartment, relatively increasing the lateral compressive force. In the case of genu varum, the weight-bearing line is shifted medially, further increasing the compressive force on the medial condyle. The presence of genu valgum or genu varum creates a constant overload of the lateral or medial articular cartilage respectively, which may result in damage to the cartilage. Here there is two images. The first one shows an increase in the normal tibiofemoral angle results in genu valgum or knock knees. Arrows on the lateral aspect of the left tibiofemoral joint indicate the presence of compression forces, whereas the arrows on the medial aspect indicate the presence of distraction or tensile forces. The second image shows a decrease in the normal tibiofemoral angle, which results in genu varum or bowlegs. Arrows on the lateral aspect of the left tibiofemoral joint indicate the presence of distraction or tensile forces, whereas arrows on the medial aspect of the joint indicate the presence of compression forces. Next, about the menisci. The relative tibiofemoral incongruence is improved by the addition of medial and lateral menisci, which act to convert the convex tibial plateau into concavities of the femoral condyles. This image here is a posteromedial view of an extended right tibiofemoral joint, showing the menisci tightly interposed between the femur and the tibia. The dotted lines indicate the wedge shape of the menisci and show how the menisci deepen and contour the tibial articulating surface to accommodate the femoral condyles. Next, about the role of menisci. First, it enhancing joint congruence. The menisci's first role is enhancing joint congruence. And this accessory joint structure plays an important role in distributing weight bearing forces, in reducing friction between the tibia and the femur, and in serving as shock absorbers. The menisci are fibrocartilaginous disc with a semicircular shape. The medial meniscus is C-shaped, whereas the lateral meniscus forms 4/5 of a circle. Lying within the tibiofemoral joint, the menisci are located on top of the tibial condyles, covering 1/2 to 2/3 of the articular surface of the tibial plateau. Both the menisci are open toward the intercondylar tubercles, thick peripherally and thin centrally. The lateral meniscus covers a greater percentage of the smaller lateral tibial surface than the surface covered by the medial meniscus. As a result of its larger exposed surface, the medial condyle is more susceptible to injury from the relatively greater compressive loads that pass through the medial condyle during routine daily activities. Compressive forces in the knee may reach 1 to 2 times body weight during gait and stair climbing, and 3 to 4 times body weight during running, with the menisci assuming 50% to 70% of this imposed load. Next, about meniscal attachments. The open anterior and posterior ends of the menisci are called the anterior and posterior horns, each of which is firmly attached to the tibia below. Anteriorly, the menisci are connected to each other by the transverse ligament. Both menisci are also directly or indirectly to the patella via the patellomeniscal ligaments, which are anterior capsule thickenings. At the periphery, the menisci are connected to the tibial condyle by the coronary ligaments, which are composed of fibers from the knee joint capsule. Next, the anterior and posterior horns of the medial meniscus are attached to the anterior cruciate ligament and posterior cruciate ligament respectively. The anterior horn of the lateral meniscus and the anterior cruciate ligament share a tibial insertion site. Posteriorly, the lateral meniscus attaches to posterior cruciate ligament and the medial femoral condyle through the meniscofemoral ligaments. Next, here is an image which is a structure of the menisci. A superior view of the menisci illustrates differences in size and configuration between the medial and lateral menisci. The medial meniscus is C-shaped, whereas the lateral meniscus is shaped like a nearly complete ring or circle. The location of the attachments of the anterior cruciate ligament and posterior cruciate ligament on the tibial plateau are also shown. Next, about the meniscal nutrition and innervation. The location of your meniscal lesion, along with the age and health of the patient, influences the options available after injury because of the capacity of the meniscus to heal. During the first year of life, blood vessels are contained throughout the meniscal body. Once weight bearing is initiated, vascularity begins to diminish until only the outer 25% to 33% vascularized by capillaries from the joint capsule and the synovial membrane. After 50 years of age, only periphery of the meniscal body is vascularized. Periphery of the meniscal body is vascularized. Once Therefore, the peripheral portion obtains its nutrition through blood vessels, but the central portion must rely on the diffusion of synovial fluid. The process of fluid diffusion to support nutrition requires intermittent loading of the meniscus by either weight bearing or muscular contractions. The horns of the menisci and the peripheral vascularized portions of the meniscal bodies are well innervated with the free nerve endings, that is the nociceptors, and 3 different mechanoreceptors, Ruffini corpuscles, Pacinian corpuscles, and Golgi tendon organs. The presence of nociceptors in the meniscus could explain some of the pain felt by patients after a meniscal tear, at least for tears located in the periphery. Proprioceptive deficits may potentially occur after meniscal injury as a result of injury in the mechanoreceptors within the meniscus. Next, about the joint capsule. The joint capsule that encloses the tibiofemoral and patellofemoral joint is large and lax. It is grossly composed of a superficial fibrous layer and thinner, deep synovial membrane. In general, the outer fibrous portion of the capsule is firmly attached to the inferior aspect of the femur and the superior portion of the tibia. Posteriorly, the capsule is attached proximal. Sorry, next about the role. Secretion of synovial fluid, absorption of fluid into joint for lubrication, nutrition to a vascular structure like meniscus. Posteriorly, the capsule is attached proximally to the posterior margin of the femoral condyles and intercondylar notch and distally to the posterior tibial condyle. The patella, the tendon of the quadriceps muscle superiorly and the patellar tendon inferiorly complete the anterior portion of the joint capsule. The anteromedial and anterolateral portions of the capsule are often separately identified as the medial and lateral patellar retinaculae or together as the extensor retinaculum. The joint capsule is reinforced medially, laterally and posteriorly by capsular ligaments. Next about the plicae. Formation of the knee joint synovial membrane occurs in early embryonic development. Initially, the synovial membrane may separate the medial and lateral articular surfaces into separate joint cavities. By 12 weeks of gestation, the synovial septae are resorbed to some degree, which results in a single joint cavity, but with retention of the posterior invagination of the synovium that forms some separation of the condyles. The failure of the synovial membrane to become fully resorbed results in persistent folds in specific regions of the membrane. These folds are called the patellar plicae. There are 4 potential locations where patellar plicae may be found because size, shape and frequency of this plicae vary among individuals. The most frequent locations for the plicae in descending order of incidence are inferior, that is the infrapatellar plica, superior, that is suprapatellar plica, and medial, mediopatellar plica. There is also the potential for a lateral plica, although they are relatively rare. Synovial plica, when they exist, are generally composed of loose, pliant and elastic fibrous connective tissue that easily passes back and forth over the femoral condyles as the knee flexes and extends. On occasion, a plica may become irritated and inflamed, which leads to pain, effusion and changes in joint structure and function called plica syndrome. This image, contains the knee joint may contain an inferior, superior or medial patellar plica or a combination of these. These plicae are folds within the synovial layer of the joint capsule and can become irritated through repetitive trauma. Next about the ligaments. The roles of the various ligaments of the knee have received extensive attention, which reflects their importance for knee joint stability and the frequency with which function is disrupted through injury. Given the lack of bony restraint to virtually any of the knee motions, the knee joint ligaments are variously credited with resisting or controlling the following. The first one is the excessive knee extension. Second, varus and valgus stresses at the knee, attempted adduction or abduction of the tibia respectively. Third one, anterior or posterior displacement of the tibia beneath the femur. Fourth one, medial or lateral rotation of the tibia beneath the femur. Fifth one, combination of anteroposterior displacement and rotation of the tibia, together known as rotary stabilization of the tibia. Next about the medial collateral ligament. Medial collateral ligament can be divided into a superficial portion and a deep portion that is separated by a bursa. The superficial portion of the medial collateral ligament arises proximally from the medial femoral epicondyle and travels distally to insert into the medial aspect of the proximal tibia distal to the pes anserinus. The superficial portion of the medial collateral ligament attaches anterior to the origin of the posterior oblique ligament and just distal to the femoral insertion of the medial patellofemoral ligament. The deep portion of the medial collateral ligament is continuous with the joint capsule, originates from the inferior aspect of the medial femoral condyle and inserts on the proximal aspect of the medial tibial plateau. Throughout its course of travel, the deep portion of the medial collateral ligament is rigidly affixed to the medial border of the medial meniscus. The function is to restrain excess abduction and lateral rotation stress. Next, about the lateral collateral ligament. The lateral collateral ligament is located on the lateral side of the tibiofemoral joint, attaching proximally from the lateral femoral condyle. The lateral collateral ligament then travels distally to the fibular head, where it joins with the tendon of the biceps femoris muscle to form the conjoint tendon. Unlike the medial collateral ligament, the lateral collateral ligament is not a thickening of the capsule but is separate throughout much of its length and is therefore considered to be an extracapsular ligament. And the function is to check varus stress and excessive lateral rotation of tibia. Next, about the anterior cruciate ligament. The inferior attachment of anterior cruciate ligament is the anterior tibial spine, and which extends superiorly posteriorly to attach to the posteromedial aspect of the lateral femoral condyle. There are two bands: anteromedial band, that is taught in flexion; posterolateral band, which is taught in extension. This image shows a posterior view of the knee joint, shows the femoral condyles to which the anterior cruciate ligament and posterior cruciate ligament each attach. Next, about the functions. The restrains anterior translation of tibia on femur, prevents hyperextension of knee, and and the next function is secondary restraint against varus and valgus motion. Next, about the posterior cruciate ligament. The origin of posterior cruciate ligament is the posterior intercondylar area of the tibia, insertion lateral side of medial femoral condyle. It also has two bands, anteromedial and posterolateral bands. Next, about the functions of posterior collateral ligament. The function, the primary restraint to posterior translation of tibia on femur, and next function, which limits the anterior translation of femur over fixed tibia in activities such as rapid descending into squat and landing from jump with a partially flexed knee. Next, the other ligaments of the knee joint are the oblique popliteal ligament, posterior oblique ligament, arcuate ligament. This image shows some of the muscles and some ligaments of knee joint. There are some muscle: gastrocnemius, semimembranosus, biceps femoris, oblique popliteal ligament. It's a view of the posterior capsule of the knee joint, shows the reinforcing oblique popliteal ligament. Also seen are the collateral ligaments and lateral collateral ligament, the arcuate ligaments, and some of the reinforcing posterior musculature: semimembranosus, biceps femoris, medial and lateral heads of the gastrocnemius, and the upper and lower sections of the popliteal muscles. The medially located posterior oblique ligament is not shown because it lies superficial to the other medial capsular structures. Next, about the ligaments of the posterior knee joint capsule. The first ligament is the oblique popliteal ligament. Proximal attachment is the central part of the posterior aspect of the joint capsule. Distal attachment, posterior medial tibial condyle. The function of oblique popliteal ligament is to reinforce the posteromedial knee joint capsule obliquely on a lateral to medial diagonal from proximal to distal. The second ligament is the posterior oblique ligament. The proximal attachment is near the proximal origin of the MCL and adductor tubercle. Distal attachment is the posteromedial tibia, posterior capsule, and posteromedial aspect of the medial meniscus. The function of posterior oblique ligament is to reinforce the posteromedial knee joint capsule obliquely on a medial to lateral diagonal from proximal to distal. Next, the arcuate ligament. It consists of lateral branch as well as the medial branch. The lateral branch of arcuate ligament, the proximal attachment is from the tendon of the popliteus muscle and the posterior capsule. The in distal attachment is the posterior aspect of the head of fibula. Next, the function is to reinforce the posterolateral knee joint capsule obliquely on a medial to lateral diagonal from proximal to distal. Next, the medial branch of arcuate ligament has same distal attachment. The medial branch inserts into the oblique popliteal ligament on the side of the joint. Next, about the iliotibial band. The iliotibial band of tract is formed proximally from the fascia investing the tensor fascia lata, the gluteus maximus and the gluteus medius muscle. The iliotibial band continues distally to attach to the lateral intermuscular septum. It inserts into the anterolateral tibia. The gird is tubercle, reinforcing the anterolateral aspect of the knee joint. This image shows the iliotibial band provides lateral support to the knee joint. In the flexor knee, the iliotibial band tends to migrate posteriorly, increasing its ability to restrict excessive anterior translation of the tibia under the femur. Next, about the bursae. There are some bursae on knee joint. The suprapatellar bursa, subpopliteal bursa, gastrocnemius bursa, prepatellar bursa, infrapatellar bursa. The anteriorly located suprapatellar bursa lies between the quadriceps tendon and the anterior femur superior to the patella. The posteriorly located subpopliteal bursa lies between the tendon of the popliteus muscle at the lateral femoral condyle. The gastrocnemius bursa lies between the tendon of the medial head of the gastrocnemius muscle and the medial femoral condyle. The prepatellar bursa located between the skin and the anterior surface of the patella. The infrapatellar bursa lies inferior to the patella between the patellar tendon and the overlying skin. This image shows the prepatellar bursa, deep infrapatellar bursa and infrapatellar bursa are separate from the knee joint cavity. The function of bursae reduce friction between intertissue junction during movement. Activities that involve excess and repetitive force at intertissue junctions frequently leads to bursitis. Thank you for watching part 1 of our lecture on the biomechanics of knee complex. In this session, we covered the basic anatomy of the knee complex, its joints, movements, ligaments, menisci, and the factors that contribute to knee stability. These concepts provides the foundation for understanding how the knee functions during daily activities and movement. In part 2, we will explore the function of knee, the screw-hoe mechanism, muscle function, biomechanics during gait and functional activities, and their clinical importance. Thank you for your attention. Please stay tuned for part 2.